Hello and welcome to Two Peds in a Podcast. My name is Dr Sarah Simons and I'm an F2 in the East Midlands. I'm joined today by Dr Ian Lewins, one of the consultants in Derbyshire Children's Hospital.
Hello.
And we're going to talk today about the kid who presents with a temperature.
Yeah.
And a little bit about febrile convulsions and what that means
Yeah.
in practice. So I think a good place to start is asking, why do we get temperatures? Why do we get a fever?
So parents ask that as a lot. Is what is the purpose? And I tend not to go into the whole physiology of things, but what I would say to folks is, look, the reason we generate temperatures is to raise our body's core temperature. We produce chemicals in response to an infection to actually raise our body's core temperature to burn off and kill off that virus or that germ or whatever. So it is a defence mechanism to in many cases to sort of protect ourselves against whatever infecting organism we've managed to pick up.
Okay, so that leads quite nicely into children with a temperature.
Yeah.
So I know that in some babies, so kids under 3 months old, we wouldn't necessarily see them always when they're unwell, but we wouldn't expect children that young to generate that raise in body temperature.
Yeah.
So a baby who presents with a fever under 3 months old is a warning sign.
Absolutely.
So that's something that you'd be concerned about.
Yeah.
And why would that be then?
So we take those children as almost as a very different group of children. That they as you say, they shouldn't really be generating a fever that high, and that should worry you, which is a complete opposite for the snotty 2-year-old. They get snots and temperatures all the time, and they sort of generate a response to this. But as you say, the neonate, the small person shouldn't really be having to generate a temperature against something. It's telling you it is likely to be something bacterial that's infecting me. And equally, their immune system, their ability to fight things off is so very different to the older child who's getting their immunity. So we would... These are sort of red flag kids, the under 3 month with a fever. And I think it's also important to say what do you mean by fever? So we would take it for that age group, any child temperature above 38, as that's a fever you have to take very seriously. And actually, sort of almost automatically, you'd be thinking septic screen. So baby with a temperature of 38.5 is straight into a septic screen and antibiotics.
So that would warrant bloods and urine and a lumbar puncture and all sorts of fun and games for a tiny person.
Absolutely.
Yeah.
And it may be nothing.
Yeah.
And you may not grow anything, and give it 24 hours, they're absolutely fine. And I would say to parents, much rather be overkill and be wrong than say it's probably nothing and be wrong.
Yeah, better safe than sorry.
Yeah, essentially, yeah. So babies are a very particular subgroup of you should be worried. Take them very seriously.
So moving on to the snotty toddlers that
Yes.
we constantly see running around the department watching Peppa Pig.
Yeah.
What's that temperature then? What would worry us about a 2-year-old, for example, who's been a bit under the weather but has a temperature of, say, 40?
Yeah. That's a tricky one to answer, because actually, when in the very small person, you're sort of saying, I'm treating a number. Almost the reverse comes into play when they're a bit older, that says, treat the child rather than the number.
Yeah.
Whereas in the younger one, I'm treating the number as well as the child. Yeah. Here, it's... So, parents often say, what's a dangerous temperature to have? To which answer is, well, there isn't really any evidence that says there's a dangerous temperature to have. Your child won't explode if it reaches a temperature of 40.5. So we sort of get, what's a dangerous temperature? Well, there isn't really. Yeah. And actually, for these older kids, you look at the whole child. You don't just look at that number. You sort of say, look, if this is a child who's hot and horribly tachycardic and tachypneic and poorly perfused, and they're clearly ill. But the example you've given of the one who's charging around with a temperature of 40, they're clearly not ill. So actually treat the child rather than the fever.
And something that parents tend to say quite often is, well, he's all right, and we've given him some Calpol, but we just can't get the temperature down.
Yeah.
And even in a child who maybe isn't eating and drinking quite so much, but enough, so is taking something, and is relatively well in himself, the fact that temperature is non-refractory is big thing that concerns parents.
It is. Yeah, and that's a very common, I can't get the temperature down, and I should be able to get the temperature down. To which the answer is, well, do you have to get the temperature down? And I think a lot of parents feel nobody's ever sort of said that to them. I think the gut reaction is, I must get that temperature down.
Yeah.
And if you sort of say, well, actually, here's the thing. Our body's generating chemicals to produce a temperature is our defence mechanism. Why would you want to undermine that by bringing the temperature sort of artificially down with paracetamol and ibuprofen? And it's a very different way of thinking to sort of to a lot of people. And this sort of concept of, the dangerous temperature and those sorts of things, and trying to sort of say, well, actually, I know they've got a temperature 40, but they're charging about. They're clearly coping with it fine. So you don't have to bring the temperature down.
I think a lot of that, like you're saying, is mismatched expectations. So helping parents understand why a kid has spiked a temperature helps relieve their anxiety to some extent. But there's still another group of parents who come in after their child's had a seizure. And a seizure is pretty scary for a parent who's never seen a child seize before.
Absolutely.
And we know that in the vast majority of these cases where you've got a kid who's been a bit snotty, a bit hot, and then has had a first-time seizure, it's a febrile convulsion. So talking about febrile convulsions or febcons, what's kind of the hallmark of a febrile convulsion as opposed to a normal seizure then?
You're absolutely right. I think that the point you touched upon there is that for many parents, having never seen this before, they think their child's going to die. And I think we as practitioners have to be empathetic to that. And equally, if you've never seen a seizure before, it's actually quite terrifying, even if you're in an environment of ED, and thinking, oh my God, this child's fitting in front of me. It's very scary. So it's important not to underplay them, because actually a lot of the kids have finished their febrile convulsion by the time they come to you. So, it's the things that we would say of a typical febrile convulsion would be, age is important. So classically sort of 6 months to 6 years, with history of fever. So febrile convulsion, therefore, must ideally probably have had a fever that's generalised. So not a focal seizure. So focal seizure is totally different and should concern you potentially. So, we often teach that focal seizure equals focal lesion, and those kids probably need a scan. So a generalised seizure that sort of lasts less than 5 to 10 minutes, that terminates on its own, and the child's pretty much back to their normal self within an hour, you would say is a typical simple febrile convulsion.
Which is quite different from perhaps a post-ictal child who's had a generalised tonic-clonic seizure that wasn't a febrile convulsion. And there's different sort of features that you could identify as part of your history.
Yeah, absolutely. And, say a lot of these children have recovered very quickly. If they're taking a long time to recover, sort of you're now 2-3 hours down the line and they're still not quite with it, you've got to think what's going on here. I mean, from my perspective, whilst I accept that, the seizure in itself as a symptom is very terrifying for parents, actually treat it as such. That's a symptom. And far more importantly, from my perspective, is why have you got the fever? What's it that's stimulated that, in the same way that you or I might have a rigor in response to something. This is kind of a child's response.
So it's seeing the fever as a presenting complaint and the convulsion as a symptom, rather than seeing the seizure as the presenting complaint and the fever as a symptom. It's recognising that kind of way round of thing.
And it's making sure that, you're absolutely right, making sure that it is a febrile convulsion. It's not something... it's not an encephalitis or a meningitis or a seizure that's masquerading as that. But if they're ticking those sorts of boxes for your simple febrile convulsion, then you're sort of thinking, okay, why have you got the fever? Because a lot of parents will say, when you sort of saying to them, as we go back, you don't need to bring that temperature down. One of the counters that they often have is, well, what about febrile convulsions? So, surely you must want to do something about that.
Yeah, and I think when you explain that this child's had a seizure because their temperature's so high, it is a knee-jerk reaction to say, well, if I bring the temperature down, does that mean that they won't seize? And then you end up in this cycle of funneling in paracetamol again.
Yeah.
And I think what you've said previously is that it's not so much about the temperature, but it's the speed at which they develop the temperature. So the onset and the development of it more so that's more relevant to that.
So and you would think it would make sense that if we're saying, look, this is a response to high temperature, that if I as a parent did something that brings that temperature down, so if I give regular paracetamol, regular ibuprofen at the first inset of snotty nose, that'll prevent febrile convulsions. That makes sense. It's also not true.
Which is interesting.
Sadly. So the research does not support that. That sort of prophylactic, if you like, antipyretics do not reduce the risk instance of febrile convulsions.
Which is a really important thing to make very clear to parents, I would imagine, in that circumstance.
Yeah, absolutely. And I think it's important to sort of get that across to them. And one of the sort of catches, I guess, is that I spend my time saying, well, we don't need to get that temperature down. We don't need to do that. And yet, when they come through ED with a fever, what do?
Exactly.
We give them paracetamol. So that's a bit of a culture change. I think we need to sort of
practice what we preach.
Debate and think about. And I must get that temperature down. Because, you'll see, again, people fairly new to paediatrics will sort of say, I've got to get the temperature down before they go home. Short answer is you could be sitting here for a very long time whilst waiting for that temperature to settle, because it might not do. And I agree, if they've had a sort of a long period of fever, so more than 5 days, you've then got to think, okay, this is a bit more than just a viral infection, because most of those should last less than 5 days. Yeah. If it's going on a longer period of time, something is not quite right here. But I'd be comfortable, as somebody who's done a bit of paediatrics, to say, you've got a temperature of 39, the rest of your numbers are okay, you look okay, I'm happy for you to go home. You might have fever for a few days, but I'd expect it to settle. Because the worst thing you can do is get the temperature down and say, go home, come back if they have another temperature. Because in a viral illness, guess what they'll do? They'll have another temperature, and they'll be back the next day, and you send them away again, and that helps nobody.
Yeah.
But it's important. So I'm happy to send home a child who's hot, but numbers are otherwise okay, versus the child who might have a very low grade temperature, but might have a tachycardia or a tachypnea or slightly oxygen. They're not right.
Yeah.
I feel far more uncomfortable about that than
an isolated fever.
Yeah, than a rampaging fever that's in a child who's otherwise totally well.
Okay. So as well as advice about using antipyretics appropriately and self-resolving nature of viral illnesses, what are the other take-home messages that you would advise a parent who's presented with a kid who's had a first presentation of a FebCon?
So important to sort of explain that, I say it's a symptom. Important to explain that in a simple febrile convulsion, one of the big worries is, has this caused brain damage? And we can fairly confidently say, no, it hasn't. In many children, it tends to be a one-off. But I can't give you a guarantee. So some children will get recurrent febrile convulsions. But generally they sort of outgrow them, if you like, as the idea is the developing brain becomes more sort of able
robust,
to compensate for or accommodate high temperatures or swings in sudden temperature. Because I think what it's important to say is, look, the suggestion is that it's not how hot you are that causes the convulsion. It seems to be maybe how quickly you go from having a normal temperature to being quite hot, and often that occurs in the first 24 hours of a viral illness. So it may be actually the presenting feature of the viral illness, and you sort of say, well, look, you're fine now, I've examined you, there's nothing really to find. I suspect in the next 24, 48 hours you'll develop diarrhoea, vomiting, cough, cold, snotty nose, and that will give us our answer. And I think that's important to say that, because it can occur very early in the illness, and they suddenly wake up, they've been on the sofa, maybe a bit under the weather, suddenly rampagingly hot, have a seizure. And that's important to reassure a lot of the time that actually it's not life-threatening. It's not. It looks horrible. They look awful, but it's not. It's not going to cause sort of brain injury or anything like that. And actually, for us, it's important not to get distracted by that. It's important to think, okay, why have you got the fever? What are the features here that should worry me and shouldn't worry me?
So I think for trainees who perhaps aren't paediatrics based,
Yeah.
so perhaps the foundation doctors or most commonly the doctors working in general practice,
Yeah.
NICE have a pretty good set of guidelines with their traffic light system.
They do.
And what would your take-home messages based around that for people who perhaps don't have that reassurance of an experienced, well-staffed children's A&E department behind them, seeing a child with a fever and a child who may have had a febrile convulsion previously?
Absolutely. I think we can be quite sniffy sometimes in ED, but we have to remember, actually, we've got hours,
An army as well.
not 10 minutes to assess this child, and we've got all the monitoring, and the GP has got a very short period of time to sort of make that decision. The thing I would say is, look, as a GP, fever is the commonest presentation to you of a child. So for those people coming into our department who are, say, GP trainees or thinking about going into GP training, I would say take that lovely traffic light, NICE guidance, print it out in colour, stick it on your door. And if you take nothing away from paediatrics, your time with us, take that away. Because that's the thing that will allow you to sort of say, okay, yes, you've got a temperature, but actually you're all green on the traffic light system for everything else, so I'm not too worried about you. I can put in place some safety netting. Or you're amber or you're red, I should be concerned about this. Somebody else needs to maybe have a look at this. So print that off, stick it on your door.
Maybe get something laminated.
Get it laminated, absolutely. CQC will go mad if you don't have it laminated. And use that. It's a really helpful guide, because one of the commonest, the presentations of parents to GPs of, I can't get the temperature down, one of the commonest discussions we have with primary care is, I can't find a focus for this fever. To which the answer is, okay, you don't actually need to find a focus.
Yeah, which is sometimes quite hard, because I think as doctors you really want an answer a lot of the time. So
yeah, and I think sometimes it's putting kind of an adult practice into paediatrics, whereas an adult with a fever without focus generates all sorts of alarm bells,
weird wonderful tests,
whereas actually a child with a fever without focus actually may well be developing their focus, but their fever is their first symptom of that. So the answer is, you don't have to find a focus, as long as you're comfortable that the thing I can't yet see isn't something serious. And that's where that sort of traffic light system will help you. So if you can say, actually, you're all green, yes, you've got a temperature, you look otherwise well, I can't find anything, the likely answer is the child's going to develop something in the next 24, 48 hours, which will be a cough, a cold, it's not a direct vomit, something like that. But actually, if you can't find something and they're red or amber, then maybe the thing that you can't find at the moment is something a bit more serious, is pneumonia that you can't quite hear yet.
It's a bit more insidious or something.
Is a urine infection. And so one of the, when we look at investigations for this, one of the key things is always try and get a urine. So trying to get a urine, which is difficult.
A skill in itself.
Yeah, difficult for us in a 4-hour limit. Trying to get one in 10 minutes for the primary caregiver is
nothing short
very
of a miracle.
different.
Sometimes.
Quite absolutely. But the absolute bottom line, always refer to the NICE fever without focus guidance. That will help you so much.
Okay. Lovely. All right. Thank you very much, Dr. Lewins.
Okay. Thank you very much.